Dr. Alcantara's interdisciplinary research integrates psychology, public health, social work, and medicine to understand how structural and social factors affect sleep, mental health, and cardiovascular health, particularly in racial and ethnic and immigrant communities. And she really applies a multi-level approach to her work, which I think you'll all appreciate. Dr. Alcantara received her PhD in clinical psychology at the University of Michigan, then went on to do a postdoc at the Harvard T.H. Chan School of Public Health, before moving on to Columbia University School of Social Work, where she is currently an associate professor. It's my pleasure now to turn it over to Dr. Alcantara, and thank you all again for joining us.
Hi, good morning, everyone. It is so delightful to be in community with you all this morning. And I have to say, for those of you who signed on a little earlier, it was the best intro music I've had to a talk. So I really appreciate that and just want to thank you all for the invitation. Thank you, Dr. Aguilera, for the invitation. It really is a delight, and I hope to someday visit in person. So with that said, I'm just going to share my screen. So give me a moment to get oriented. And I couldn't resist but to talk to you all about some of this interesting research that I, along with some colleagues, did around the disaggregation of Latinx health data and really presenting this 50,000-foot view. And I'll do that as a point of departure to then talk about my research on sleep in Latinx community, and also translating some of those findings to behavioral health intervention research. Nothing to disclose. This is a more concrete outline of what I just said, but again, want to present this 50,000-foot view about what do we know in terms of the disaggregation of Latinx health data for research that uses public health surveillance data, and then use that as a starting point to talk about my research on sociocultural factors and sleep in Latinx communities, and end with sharing with you providing an overview of cultural adaptations and behavioral interventions for sleep in behavioral sleep medicine, and this Dormir Mejor study, which is a randomized controlled trial that is currently underway that really tries to bridge some of the data that I'll present on sociocultural factors in sleep within an intervention science framework. So it'll be exciting to talk to you all about that today. So in my I have 3 lines of research, which Dr. Aguilera alluded to. Really, I can sort of put them into 3 different buckets, but they're not that neat, and they overlap. There's one line of my research that really squarely focuses on understanding Latinx health, and particularly understanding variation in Latinx immigrant health. I have another line of research that's focusing on understanding understudied aspects of the psychosocial context and its relationship to cardiovascular health, and then a growing body of research, particularly in the last, 8 or so years, that have focused on understanding sleep disparities and the relationship between sociocultural factors and sleep and in Latinx communities. I'm going to talk to you today about my work in sleep disparities, but also some of the broader work I've done in Latinx health. And I think that's an important note. All of you who are in the audience with social work background, the ecological frameworks and Bronfenbrenner's ecological framework, among others. And I highlight this social determinants of health framework, which is coming from the World Health Organization, which from my perspective it's another really great ecological framework. And I highlight this to show that this is really a guiding framework in all of the research that I do, and the research questions that I ask, and how I interpret data, where the goal is to really understand how structural and social factors have both direct and indirect effects on health and well-being, indirect effects through the ways in which they might shape exposure to risk and access to resources, whether they're material circumstances, behaviors, biological factors, or psychosocial factors. So you'll see me talk a little bit about, or refer to this model throughout this presentation. And so now to what I was really excited to talk to the Latinx Center of Excellence about today, which is some of the work that I and some colleagues, including Leo Cabasa, who I know spoke here a year ago, which is the results of a RWJ funded project that we did that tried to characterize the state of the evidence of the disaggregation of Latinx health data. And what we did was, it was really, I don't know if you've done a systematic review, I'm sure many of you have, it's there, you either love them or hate them. You probably hate them while you're doing them, but then you love sort of the outcome. And I would say that's probably how we felt about this one. But our charge was to understand the barriers and facilitators to data disaggregation, particularly of Latinx health data and public health data in particular. And so one way that we did that was to first conduct a systematic review to get a lay of the land. We looked at all published research on several prevalent Latinx child and adult health outcomes. And we had several aims. I'm just listing the first one here, which is to really understand again that like 50,000 foot view, to what extent is this public health data being disaggregated or stratified by some of these social determinants that I may have referred to in that model before. So, non-medical factors. So think it can be related to your socioeconomic position, like race, ethnicity, immigration status, place-based factors, with the idea, gender, with the idea to see to what extent is this data on Latinx health providing within group comparisons. So we took a 10-year snapshot, and what we found overall, and I'm happy to take questions about this later, is that from all this data that we reviewed, which was close to 1,900 articles in that period, about 30% of those articles actually provided some kind of within Latinx within group comparison. So instead of presenting estimates for one entire group, they were providing health estimates that compared, either by sociodemographics or by migration factors or by place-based factors. So only 30%. The majority of these data that did provide some within group comparisons were focused on adults, so close to 78%. Of that disaggregated or stratified health data, only about 23% were focused on children. And lastly, of those included articles, just about a third included or provided even summary statistics of the percentage of immigrants in their population. We, as I mentioned, we were interested in to what extent do these our public health data that focus on specific health outcomes, presenting within group comparisons, and trying to understand, have there been any trends over time? What we found is that the average was about 15, close to 16, 15.9 articles published per year. There's some variation. There's a lot more research that disaggregates Latinx health data that focuses on adults, and fewer research that focuses on children. But again, I think overall it seems like it's been pretty. There's been some dips, but pretty consistent that there hasn't been any major increases over time. I think really important for all of us who are interested in behavioral health is, from this 50,000 foot view, a lot of the articles that were included focused on physical health. So they provided, within group comparisons that would stratify, health estimates about heart disease or diabetes or cancer or unintentional injuries, for physical health outcomes. None of the articles focused on cerebrovascular disease. And then when you focus on mental health, only about a third for adults provided some kind of disaggregated health data for mental health outcomes. And among children, it was even less than that. It was about 15% of that literature that provided within group comparisons for Latinx child data. I think this is the part that's also fascinating. And at the SWIR meeting, for those of you who attended last week, we had this interesting conversation about, the construct of culture and sort of the state of where we are, and how do we how do we incorporate those constructs into our research? And I think one of the points that I had tried to make is that we, for those of us that do this research, we understand that there's substantial heterogeneity within the Latinx population, and it's something that we recognize. But in terms of the research that's being published, where disaggregation, understanding this within group differences is only happening in about 30% of those the papers that were published. And then when we look specifically, well, what kinds of within group comparisons are they doing? This is a busy table, so I just want you to focus on what's in the oval here. About 61% of the articles provided within group comparisons based on sociodemographics, if we include gender or age or marital status. About 18.5% provided some within group comparisons by socioeconomic status, about 11% within group comparisons by migration-related factors, about 8% by place-based factors, and then very few that focus on some of these interpersonal or individual factors like discrimination or social support. So in terms of those within group differences, a lot of them have focused on this sociodemographics and a lot fewer. I think interestingly, which I found fascinating, for the literature on children, a higher percentage of those articles disaggregated by migration factors versus the adult health literature, where a higher percentage, so here, for example, 7.8% that disaggregated by place-based factors versus the child data that were only 2.4% disaggregated by place-based factors. So I sort of provide this 50,000-foot view. One, I think it's really exciting work that I was able to collaborate with some terrific colleagues on in this area. I think two, there's still work to be done. And so in this project that we did, the systematic review was one part of what we did. We also conducted qualitative interviews with key stakeholders to understand barriers and facilitators to disaggregating data. So thinking at, talking to folks who are responsible for collecting some of these large public health surveillance data, and what are the barriers to then getting some of these fine-grained measures that would allow one to do disaggregation. And so what this sort of shows us is that it's happening, reporting of disaggregated data is only happening about 30%, and that there's probably a need, for ongoing conversation as to how we standardize, incentivize, I think, promote disaggregation. And I would argue both in, theory, sort of research design, all the way to analysis and interpreting the data. And so with this disaggregation sort of framework in mind and social determinants of health in mind, I want to turn to talk about my research on sociocultural factors and sleep in Latinx populations, and use this as an opportunity to illustrate how I approach, I really sort of hold on to this perspective about trying to understand heterogeneity within the Latinx population, or key factors that might be important in shaping experiences of health. I'll backtrack a bit to talk a little bit about why sleep is important, and really quickly say that we know that we spend about 1/3 of our lives sleeping. Sleep looks the same across cultures. It's really characterized by this neurophysiological state of quiescence. Your body is still. And there are very clear recommendations in terms of how much sleep we need. If you focus on adults, the current recommendation is that we need is for 7 hours or more. We know that there's changes across the lifespan with newborns and infants needing more sleep, and the recommended hours of sleep decreasing over time. And even though we know how many hours of sleep we need, the reality is that only 1 in 3 US adults are sleepless. They're not obtaining enough sleep. And in fact, they're sleeping less than 7 hours per night. This is based on a CDC map using Burfist data that I think makes really clear that there are significant geographic variation in the percentage, in the prevalence of short sleep duration in the country. And you see, in fact, that there's higher concentrations of insufficient sleep or short sleep duration concentrated in the South. In California, you also see this regional variation. Even within the state of California, we see this, I think, when you look from state to state for where there's, in general, more than 1 in 3 adults in California are sleepless. It's closer, I think, to 32, 33%. And you see that there's a higher prevalence of short sleep duration concentrated in more Southern California. So it's good. You all closer to the Berkeley area get have lower prevalence of short sleep duration, although this is, of course, is all pre-COVID data. So sleep, it's not just that we're not getting enough sleep, but part of the reason why we care is that there's been substantial evidence to show that sleep disturbances contribute to poor health, including increased risk of cardiovascular disease, depression, obesity, diabetes, cancer, death, and work absenteeism, just to name a few of these adverse health outcomes. And sleep loss is also tied to very severe industrial accidents in the US. And these are some that are listed. In New York, for example, there was a derailment of the Metro North, one of the major transportation systems in New York, where it was found that the conductor fell asleep and had while operating the train, and it turned out that he had undiagnosed sleep apnea. So these sleep loss is associated with well-known industrial accidents, and including driving while drowsy, which is a significant risk factor for automobile accidents. It's no surprise then why improving sleep is a national public health priority. It's part of the Healthy People 2030, and there are several objectives that are focused on improving the nation's sleep health within Healthy People 2030. And, we know that sleep is associated with that we're sort of sleepless in America. And so why is it so hard to obtain sufficient sleep? At a one level, you can look at some of the cultural beliefs that the individual people may have. So on one hand, it could be that sleep is considered a luxury that's optional, particularly in a 24-hour society where sleep loss is considered a status symbol. On the other hand, sleep might be considered a necessity and part of a biological drive that you have to meet. But I mean, that sounds pretty simplistic. And as social, work researchers, I think as I know that there might be some folks from public health and other disciplines, just when you take this ecological framework, you know that in fact, there are structural constraints that shape whether someone's able to act upon these individual beliefs. So specifically, whether structural constraints like living in poverty, holding multiple jobs, commuting long distances to and from work, neighborhood factors, so these place-based factors, exposure to financial hardship and homelessness, all these structural factors that constrain whether someone can actually act upon these beliefs or not. And so, from that perspective, I, just come back to the social determinants of health framework, which is trying to understand how, how these structural and contextual factors affect sleep, and both have their direct effects and indirect effects on sleep. And that's a bulk of this is a main framework that I utilize in my program of research, which I stated earlier. And in understanding that, with colleagues, we've documented evidence of racial ethnic differences in sleep disturbances, such that sleep disturbances are not evenly distributed across racial and ethnic groups. And these are data from a multi-ethnic study of atherosclerosis, where what we found was that for racial ethnic minorities in comparison to whites who are in this darker blue color, had a higher prevalence of severe sleep disordered breathing or obstructive sleep apnea, objective short sleep duration here, and some less consistent data for insomnia. But these findings are pretty consistent, that racial ethnic minorities are more likely to suffer from sleep disturbances like obstructive sleep apnea and sleeping less than 6 hours. I just want to sort of pause to acknowledge, I just presented racial ethnic differences data, and it's really important to be very specific and concrete in the terminology that we're using. So while I may refer to racial ethnic differences or highlight a race ethnicity variable. What we know is that race and ethnicity are social constructs, right? That they're reflecting, in fact, experiences and exposures to institutional or structural racism. So they do not, in fact, reflect genetic differences. And the race ethnicity variable is, a proxy for the racism that someone might face. So just important note on terminology. So what contributes to these sleep disparities? This is one of the questions. I can't say that it keeps me up at night. I try to prioritize my sleep, but this is one of the questions that I do think a lot about, and specifically trying to understand and focus on these intermediary level factors that might explain how these socioeconomic position factors like race, ethnicity, immigration status, education might in turn affect sleep or mental health outcomes, and in particular focusing on these stress pathways. And so there's been a lot of well-established experimental research and community research to show that exposure to psychosocial stress is associated with multiple dimensions of sleep health. We know that Black, Indigenous, and people of color, they face specific stressors that are associated with their marginalized status, such as ethnic discrimination, such as acculturation stress, that are not typically captured by standard measures of stress. And in fact, there's been more work focused on understanding the relationship between ethnic discrimination and sleep, and some well-substantiated evidence to show that ethnic discrimination is strongly associated with self-reported sleep in racial ethnic minorities. I was really interested in understanding if disparate psychosocial and sociocultural stressors, and in particular both taken into account ethnic discrimination and acculturation stress, were associated with sleep in a Latinx sample. And so that's what we did in two different studies. And I'm just gonna, again, sort of present some important guiding pieces of information and then some of the highlights of what we found. In this first study, what we were interested in examining that same question that I said, which is, how are these three different stress exposures associated with various different kinds of sleep outcomes, so sleepiness, insomnia, sleep duration. In this paper, we use data from the Hispanic Community Health Study, or the study of Latinos, which are cross-sectional data. Again, we had self-reported stress measures and acculturation stress measure that focus on the last 3 months, an ethnic discrimination measure that's more of a lifetime exposure to discrimination, and then a chronic stress burden, which was self-reported stress experience for 6 months or longer. And in this paper, we were really interested in trying to understand if the relationship between these stress exposures and sleep would be modified by gender. And we had hypothesized that the effect of these stress exposures would be greater among women than men, given previous research to show that stress that has found this relationship to be stronger among stress and behavioral health among women than men. And so this was a large sample of about 5,000 Latinos. I'll stop to put in a plug for the Hispanic Community Health Study, or Study of Latinos. It's the largest study of Latinx health ever conducted. Its baseline assessment included about 16,000 Latinos. It's a community foresight study where Latinx adults were recruited from the Bronx, Chicago, San Diego, and Miami. There's been several ancillary studies that have come forth from this, the Hispanic Community Health Study, and it's just a rich data source. So for those of you who are interested in kind of these data, happy to have other conversations with you about this data set, but it's just a plug. And so what did we find? What we did is that we conducted both individual models where we looked at each stress exposure and its association to those various sleep outcomes separately. And then we conducted aggregate models where we entered all of the stress variables together, including with progressive adjustments for covariates. What I'm showing here are the results for the relationship between these psychosocial and sociocultural stressors and insomnia symptoms in one model. And what we found in both our very, in both of our adjusted models is that acculturation stress and ethnic discrimination and chronic stress were all associated with increasing insomnia symptom severity, even after adjustment for important sociodemographics and behavioral risk factors, and also depressive symptoms. In a follow-up study to this, we wanted to build upon, I should say we didn't find any evidence that gender modified those associations, which was unlike what we had predicted. In a follow-up study, what we wanted to do was to really sort of build on what we found, but here focusing on combining the Hispanic community health study of Latinos, their sociocultural ancillary study with their sleep study. So it was bridging a lot of my interests together to look at this combined sample where we had the same stress exposures that we talked about, but this time we had much more refined measures of sleep outcomes that included also objective measures of sleep that were collected with actigraphy, and a more clinical measure of insomnia that's well established in the literature. These are all still cross-sectional data, and our sample here was smaller in particular because of the objective sleep data that we included. In this paper, given that social determinants of health framework and that disaggregation framework, we were interested specifically if employment status served as a significant moderator of the relationship between these stress variables and insomnia. And part of the conceptual rationale for that is that we thought, much like I had talked a little bit about before, that sort of increasing stress was going to be associated with worse sort of sleep outcomes depending on how they're measured. So higher insomnia severity, higher sleep variability, lower duration, and lower efficiency. But that employment status was going to modify this association. In particular, we thought that this association would be stronger among those who are unemployed, because for those who are unemployed, it might be that they might be exposed to environmental factors or engage in certain behaviors, for example, lying in bed, sort of ruminating, having more sort of opportunities for to engage in some of these maladaptive sleep practices that would worsen their sleep. And so that was some of, or, you know, the unemployment status might be associated with exposure to environmental factors that might affect their sleep, whether it's the neighborhoods that they're living or, you know, where they're sleeping, et cetera. And so when we tested that again, taking what I'm showing you here is those 3 stress exposures in one model. And what we found in this sample, where our outcome was a more clinical measure of insomnia symptom severity, is that acculturation stress and chronic stress burden remain significant correlates of insomnia symptoms, whereas in this sample, ethnic discrimination was not. And in fact, employment status did modify the effect of acculturation stress on insomnia symptom severity. And you see here acculturation stress represented on the x-axis and insomnia symptom severity represented on the y, where the effect is stronger among those who are unemployed, that dashed line. For this paper, we were interested in examining the employment status, which I just showed you as an effect modifier, which I just showed you the results of that paper. We were also interested, again, I think conceptualizing or keeping this disaggregation perspective into account. And we tested for within group differences by nativity status, whether they were born in the US or immigrants, and that did not, nativity status was not a significant effect modifier. Gender also was not, did not significantly modify these associations either. And so just sort of kind of wrapping up these 2 studies, both the source of stress and the chronicity of stress burden were associated with sleep quality, but none of the objectively measured sleep sleep outcomes that we included, like duration or efficiency. I think what's interesting is that, you know, so we found the effects for both, particularly in study 2, for both acculturation stress and for chronic stress burden. I think one important point to note is that both the acculturation stress measure and the chronic stress burden measure, they're both getting at something that's acute and chronic, versus the lifetime, the ethnic discrimination measure that we used is asking about a lifetime exposure. And so in terms of tying that to your current, you know, the extent to which this lifetime exposure would be linked to your sleep today, it leaves a lot of unanswered questions. And so it might make sense why we didn't see a consistent effect with exposure to ethnic discrimination. It could be that self-reported sleep duration may overestimate the effects of stress on sleep duration. And so specifically, we saw those consistent findings for the self-reported sleep outcomes, but not for objective sleep. For those of us who study sleep, we often also like to emphasize how sleep is this multidimensional concept. So you're not always expecting to see that the relationships would look between stress exposures and sleep would look the same across all these different dimensions. So it's possible that there's an exposure that might affect duration, but may not affect efficiency or quality or your perception of your sleep, but it might affect how much sleep you're getting objectively. And then lastly, these are cross-sectional data. We can't say anything about causality. The temporal order is really not known. I think one of the big takeaway points for me is just the importance of acculturation stress in this sample. And this included both US-born Latinx sample and immigrant Latinos. And it's possible that acculturation stress may promote vigilance, which in turn may negatively impact the initiation and maintenance of sleep in Latinx populations. And for me, you know, this has been pretty part of the formative work that has helped sort of serve as a springboard for thinking about behavioral sleep medicine interventions that target the resolution of sociocultural stress, or that at least incorporate attention to sociocultural stressors like acculturation stress. And so I wanted, with the time that I have left, I just want to sort of quickly tell you a little bit about some of the behavioral sleep medicine interventions and how I'm applying what I just shared with you from the quantitative data on sociocultural factors in sleep into an intervention. And how and why our team did 2 systematic reviews at the same time, I don't know, but happy to say that this is in press. And what we did with this systematic review is, again, wanting to take the 50,000-foot view of what do we know about behavioral sleep medicine interventions and the extent to which they're adapting interventions for underserved groups. And so this was a massive systematic review of all behavioral sleep medicine randomized controlled trials from inception to December 2019. And we wanted to understand issues of representativeness. We wanted to examine, using a cultural adaptation framework, what kinds of cultural adaptations did they make, and also qualitatively describe how effective the interventions were. And from, again, this large review, what we found of all those behavioral sleep medicine randomized controlled trials, only 7% targeted an underserved group, which we have defined here on the right-hand side. And I just want to draw attention that none of those behavioral sleep medicine randomized controlled trials focus on immigrants, on LGBTQ plus populations, on linguistic minorities, and only about 9% focused on racial ethnic minorities. So these were the underserved groups that we included, and the extent to which those behavioral sleep medicine RCTs included these populations. Quickly, and just really quickly in terms of which of these psychological interventions were adapted. By and large, most of the adaptations were made to cognitive behavioral therapy for insomnia, followed by about equal percentages for behavioral therapy and cognitive behavioral therapy, and then about less than 7% of the studies that we included that made adaptations for mindfulness-based stress reduction, ACT. I'm happy to sort of take questions about the interventions in the Q&A. But by and large, most of these adaptations happened to CBTI, were made to CBTI. Now, what did we find in terms of cultural adaptations? And I'll say that we used the cultural adaptation framework that was presented in an article by Barrera et al. From 2013 to really try to understand, the extent to which surface level adaptations were made or more deep level adaptations, where surface level adaptations are adaptations that are associated with the presentation features. So this could be merely translating the intervention into Spanish, into a target language, versus a deep level adaptation could include really changing and modifying, including cultural values into the intervention that reflect the target population. And so interestingly, from the articles that we included, about 60% conducted surface or deep level cultural adaptations. The majority of those adaptations were surface level adaptations, which you can see here represented on this red to orange spectrum, where about 59% made changes to delivery modality, about 33% made changes to the setting, about 19% to the treatment duration, and others sort of that included changes to the timing of the intervention, including role models or other constituent involving strategies, versus the deep level adaptations. Most of the changes occurred were changes to the content in terms of incorporating content that was hypothesized to be of relevance for that target population, or changes to core components. So one example of that would be adapting CBTI to include discussion of fear of recurrence of cancer for an intervention of CBTI that was for women who were recovering from breast cancer. So that was a change to one of the core components, or even of the intervention. So these are just some examples, and again, happy to take more questions about that. And, I found this really illuminating. We didn't know what we were going to find. And it was really interesting to focus on, to see what had been done with insomnia, to realize that a lot of adaptations had been or made to insomnia, and the fact that there were really clear gaps in terms of the fact that none of these adaptations had focused on delivering CBTI to linguistic minorities, so non-English dominant speakers. And so sort of took this along with the fact that insomnia is actually increasing in prevalence among the Latinx population. And these are data from the National Health Interview Survey that showed that in 2012, it was as high as 19.3%. And interestingly, and I'm focusing on cognitive behavioral therapy for insomnia because it's considered the gold standard treatment for insomnia. And what's interesting, and there's been lots of studies to show and to document its evidence base. There are barriers, though, to receiving this specialty treatment, including that insomnia is viewed as secondary. There might be inaccurate beliefs about the importance of sleep. So, manage your depression, and then you'll manage your sleep, manage your anxiety, and then you'll manage your sleep. There's also issues about access in terms of to providers who have been trained in this modality. And overall, like I showed you with the results of the systematic review, there's been a lack of attention to contextual language, literacy, and cultural factors more generally. And so we sort of used, the results of this systematic review, the results of the two studies that I shared with you before. We also conducted qualitative focus groups with about 35 Latinx participants, both Spanish speaking and English speaking. And from those focus groups, again, the importance of the salience of acculturation stress and migration related familial stress was one of the key themes. Participants also talked about a strong aversion to pharmacotherapy, and how 94% said that they would use a health app if it was recommended by their healthcare provider. So some interesting qualitative data that supported some of what we found in the quantitative data. And so I know Dr. Aguilera is in this space, so I'm really excited to sort of get some perspectives on this. In terms of digital health and CBTI access barriers, there's been a lot of enthusiasm about the potential to use these digital therapeutics as a means to expand access to CBTI for underserved communities. And in particular, for non-English dominant speakers, so Spanish speakers or other languages, and there might be a potential for faster uptake of behavioral health care because of potential reduced barriers to receipt of treatment. So some of the barriers in terms of access to high quality care. In the case of insomnia, there's lots of actual digital therapeutics. This is a thriving business with some folks that might even be based, have offices in San Francisco, so not too far away from you all. And some of them have better, more well-established evidence than others. And the Dormir Mejor study, which is an R01 funded project that I will tell you about soon, is a collaboration between Columbia School of Social Work, Pear Therapeutics, which is one of such companies that is the developer of Somryst, that has a company out in San Francisco, and also this 11-person bilingual English and Spanish community advisory board, or CAB. And this is an AHRQ funded R01 that's a hybrid type 1 trial and a mixed effectiveness implementation study where we have 3 aims. The first aim is to use a rigorous cultural adaptation framework to adapt a digital treatment, Somryst, which I'll tell you about shortly. After that cultural adaptation process, to conduct a randomized control trial comparing this adapted Somryst adapted intervention to enhance usual care. The second aim is to do this multi-stakeholder evaluation to understand barriers and facilitators to potentially implementing a digital treatment in primary care for Spanish speakers. And the third aim is to really look at cost effectiveness. I'm happy to talk in the discussion too about this process and what it's like collaborating with behavioral health technology company, it's a very interesting process. We are in the stage 3 and stage 4 of our cultural adaptation framework. We conducted virtual focus groups in May of last year. We've have a beta version of the digital treatment, and we're actually going to have some one-on-one interviews that we've had to adapt to be able to do it virtually, and some usability testing that we are poised to start in February, with the idea that once we finish this very rich and rigorous cultural adaptation work, we'll be able to start the randomized control trial. And this is a bit of what Somryst is. So Somryst is the first FDA-approved digital therapeutic for insomnia. It's really cool and an interesting and novel advancement in the space of digital therapeutics, because they have FDA authorization for the treatment of insomnia among adults and have well-established evidence base for this intervention among English speakers. And so we've been working with them to adopt this for Spanish speakers. We've have been relying on our community advisory board and participant feedback and all of that quantitative and qualitative work that I presented to obtain feedback on precipitating and perpetuating factors of insomnia, on the characters that are featured in the persona and the expert personas, on sleep hygiene guidelines, and really health literacy has been one of the key issues. So attuning to issues of health literacy, both in the content, in the animations, and issues of numeracy as well in the concepts. That's been a major focus. To date, we've made about 71 different kinds of adaptations, a lot. Importantly, about 82% of those have been these deep level adaptations. Some examples of that have been adapting the vignette characters to reflect the diversity of the Latinx population, really leveraging and leaning into the familismo cultural value in the vignettes and our video vignettes, and I can talk more about that. Really centering the immigrant experience. That's something that we keep learning time and time again in this group of our Spanish-speaking participants who are experiencing insomnia. Like when we try to talk about like racism or any other important or their race or sort of social identity, it really comes back to their immigrant experience. So really making sure that that is centered throughout the entire app and their country of origin identities, incorporating culturally relevant examples and proverbs, and a big shift, and that's so important in this digital space is, making sure that we're at a sixth grade reading level, really attuning to health literacy and captioning as well. And just sort of to give you, I won't go into depth about this, but when we launch to the trial, we'll have participants who will be randomized into the Spanish Somrist or enhanced usual care, and it'll be followed up by there'll be outcome assessments at 3 and 6 month follow-up. And so we are the cultural adaptation and final digital adapted version of Somrist will be ready in May of 2021, and we're optimistic to start enrolling into the RCT shortly thereafter, and the RCT will conclude about 2 years after that. So in summary, I presented a lot. I know I can't help it. I was so excited. But I think, again, I just want to, come back to this point that I started with, which was about the importance of disaggregation of Latinx health data and really making sure that that's an a priori consideration. And, I encourage for those of you who are interested to check out the article. We talk about the fact that the low percentage of overall of disaggregation indicates that there's a need for programmatic initiatives across the research process to standardize both the measures and the approaches to disaggregation. I think in terms of sleep, something that's just so important, and I'm not the first to say it, there's other colleagues who talk about sleep disparities as a social justice issue that require these multi-level, multi-domain interventions. And I think to the extent that we can, even if you're operating at the individual level, really design interventions that are aware of the these upstream factors, whether it is employment status or immigration status, to really be able to enhance the potential effectiveness of these interventions. And, lastly, I think there's a lot of challenges to do in this digital space, and also opportunities in the potential use of digital therapeutics for behavioral health in marginalized communities. And, we sort of as a team at Columbia, we're learning a lot, and I think we're going to learn a lot from this process in terms of what may or may not work. So I just want to acknowledge the small but mighty team at Columbia across on this coast, who are part of the Sleep, Mind, and Health Research Program, and also funding sources and lots of community partners. I didn't talk about that today, but lots of collaborations with various different consulates in New York City and community organizations and Latinx facing community orgs in New York. So I'll stop there and just thank you for your attention, and I'm looking forward to our Q&A.
Thank you so much, Dr. Alcantara. As y'all can see, so much great work that's really benefiting the community, centering the neediest folks, the Latinx population in particular. So now we have about 10 minutes to open it up to any questions that you might have.